cystic fibrosis. We're going to be talking about the pathophysiology of this disease and the treatment. And really, we're going to be trying to emphasize the pharmacist's role in the treatment of this disease. So we're going to start with a case. IR is a 6-month-old boy who's seen in urgent care for a deep hacking cough. He has a history of several colds and was diagnosed with RSV, which is respiratory syncytial virus, along with his twin brother about 3 weeks ago. And he is in some distress and has expiratory wheezes upon examination. His weight is at the 25th percentile and his height at the 50th percentile for his age. His fraternal twin is at the 90th percentile for weight and 75th percentile for height. His appetite is good, but his mother states that as if the food is going right through him. So if we do a SOAP on this patient, subjectively, this patient has a hacking cough in a child that has just finished or has had respiratory syncytial virus. He has objectively has a temperature of 107 degrees Fahrenheit, has an increased respiratory rate and expiratory wheezes, has an increased pulse, which is regular, and has a chest x-ray that shows a right middle lobe infiltrate, and the assessment is probably pneumonia. The plan is to get a sputum for culture and sensitivity to see what might be causing this, and gave an IM injection of 500 milligrams of ceftriaxone and put him on oral augmentin for 14 days, and gave albuterol solution for inhalation that should be given 4 times a day. Also has a prednisone oral solution taper and has ordered a cystic fibrosis sweat test. A cystic fibrosis sweat test is a diagnostic, or one of the things needed for a diagnosis of cystic fibrosis. So what is cystic fibrosis? It is the most common and severe inherited genetic disease among Caucasians. There's about 30,000 people with this disease in the United States, and it has more than 7 million carriers in the United States. By the way, there's about 70,000 in the world with this disease. And about 1 in every 25 Caucasians is a carrier of this disease, but it's found in every race, but it's much less common in those of African descent and those of Asian descent. The median survival right now is about 50 years, which this has shown great promise. The cystic fibrosis name for the disease was coined in 1938, which maybe sounds like a long time ago for many of you, but it really wasn't very long ago, less than 100 years since we've actually named this disease. And it was describing what the pancreas of these kids that died very young looked like when they did autopsies. It was cystic and fibrosed. And so the pancreas was really what determined the name of this disease in 1938. However, there's writings back to 3000 BC in German folklore that described salty children as being bewitched. So if you kissed your child on the forehead and it was salty tasting, then they would die young. So they die as a baby. So we do think that it's been around for a long time, but it wasn't described until 1938. So people don't really necessarily know if it runs in their family or not, since this is a genetic disease. In 1989, I remember this day when it was announced on the radio that they found the gene that encoded the CFTR. So the problem with this disease is there's a gating mechanism that is in the surface of, in the apical surface of secretory cells, that this gating system is not functioning for some reason. And the gating system is called, it's been named the CFTR, the Cystic Fibrosis Transmembrane Conductance Regulator. And when the CFTR was cloned in 1989, everyone thought, oh, there's going to be a cure like in a couple of years. Well, it's now what, 2024. So that's 24 plus 2011, right? So it's been 35 years and we still don't have a cure. We're certainly making big progress though on this disease. In the 1940s, when this disease was named, these kids that were born with this disease did not get out of infancy. They died before they died, usually in the first year of life. And by 1980, we had improved the life expectancy to about 18 years of age. And today, I don't know where it's going to go because we've had so much progress in the medications we have. And therefore, we can be very hopeful about how the survival or the longevity will improve. And this is just a kind of a graph that shows, you can see here in 1938, when it was when the disease was named. Before then, you just had very little chance of getting out of infancy. And then as we added things to help with the disease, as we learn more about the disease, you can see the life expectancy going up. And with our new, all these things up until here, none of these are actually getting at the cause of the disease. These are just all trying to treat the symptoms, trying to treat what's happening, not the actual cause. And then in the early 2000s, 2010, we started having these disease modulators, and really they're CFTR modulators. So we're actually going after the problem for the first time, and these are going to change the life expectancy drastically. Exciting! It's a science win, everybody! Yay! Just quickly, the CFTR, as I said, is a gate at the cell membrane that's responsible for chloride ion transport. So here's a normal CFTR, and chloride is able to move through here and regulate the liquid on both sides of this cell surface. So this would be like in your sweat glands, respiratory tract, pancreas, and others. Actually, the sweat gland, this is opposite, but in the respiratory tract, pancreas, and other places where mucus is made, or we have liquids here, secretory, this regulates this, so the chloride can go out here and make sure that it's one of the things that regulates the outside of the cell. And in this case, it shows airway surface liquid that lines the respiratory tract. If you have a mutated CFTR, like we see in CF, then the chloride cannot get through here. And therefore, we know that sodium and chloride will pull water. So we have water going inside the cell, where normally it's being able to move back and forth here, and it can't get out here. And what we end up with is mucus that's very thick and unable to do its job, which causes a great place for bacteria to live, and you can't actually move it. It's like thick and icky, and the cilia that are here that normally move the mucus along are damaged, and therefore you can't get a normal movement of the mucus, and the mucus ends up not being a help but a hindrance to the lungs and other secretory systems, and causes inflammation and damage, and in the lungs especially, that's usually the cause of death. This is a picture of the CFTR. Isn't it cute? It looks like a ribbon you want to put on your package. I think it's cool that we can see how this, so this is, you can see that there's lots of folds in here, and the folds become important in certain types of CF mutations. Okay, that's it for this one.